This is Gagan Atreja on behalf of ARIS, welcomes all the delegates in this Crevast Academy. We have been having many events under the umbrella of Crevast Academy. Now, ARIS Life Sciences believes strongly in its value system, and our value system is power of empathy with the truth of science. And our various patient care initiatives have justified our practicing ARIS values like CGM on call, vascular screening, Holter monitoring, Insight, Cardinal, India Heart Study. There are various patient care initiatives which we have been doing in the market with all of you, which justifies the practice of our values, that is power of empathy and truth of science. Keeping the same belief, we created with the help of many leading cardiologists and diabetologists across the country, this academy called Crevast Academy. Now, under this platform, we will be having many events around the year. Now, during these events, we try to disseminate and master the nuances in clinical management for improving CV outcomes. And our eminent faculty members, they guide the clinicians across India to improve CV health in patients. The first event which we had under the platform of Crevast Academy, that was on 8th April 2023, and the topic was statins essential for diabetic heart. And we had speakers, Dr. B.C. Srinivas, Dr. Matthew John, Dr. Rajneesh Kapoor, and the moderator of the whole session was Dr. Sanjeev Shah. And the second event we had on 13th May, where the topic was statin optimization, the need of the hour. And the eminent speakers were Dr. M. Srinivas Rao, Dr. Sadanand Shetty, Dr. T.R. Muralidharan, and again, the whole session was moderated by our Dr. Sanjeev Shah. So today, we have yet another topic, very interesting, under the umbrella of Crevast Academy, the battle against arterial plaque with statins. And today again, we have none other than Dr. Sanjeev Shah, who is a senior diabetologist and endocrinologist from Mumbai. Dr. Sanjeev Shah is attached to Nanavati Max Super Specialty Hospital, Mumbai. He is an academic clinician in private practice for the last more than 40 years. He was attached with KM Hospital for more than 5 years as a clinical pharmacologist, and he has been the researcher in many global trials in diabetes for the last more than 20 years. Not just this, he has more than 50 original research papers and 20 book chapters to his credit. So we have Dr. Sanjeev Shah with us, and I'll request him that please run the show today, run the event today, and moderate the whole session. So wish you all the best. And sir, Dr. Sanjeev Shah, over to you.
Thank you. I would like to share the screen. So friends, today's topic is more against the plaque or the block which we refer to, and that is responsible for large majority of coronary events. And our focus is going to be how do we fight the battle against arterial plaque, specifically in coronary arteries. But the plaque does not mean that they happen only in coronary arteries, but they do happen in other vascular beds also. So we are going to have 3 experts, 3 cardiologists, and the subject is being divided into 3 different headings. The first being the coronary artery calcium score. We selected this particular title and the subject in keeping in light that this is what is going to be the predictor of future cardiac events. and this is probably going to refine the diagnostic skills of our practicing physicians across the country. Over last couple of decades, a lot of research has happened on this subject. In the second part, we would have post-myocardial infarction. How do we treat and what kind of a treatment differs from primary prevention? And in the later part, we would go into the little more sophistication into impact of our therapy on arterial plaque and some of the evaluation which could be done by intravascular ultrasound in coronaries or by artificial intelligence. Now, do we have a clinical way to predict who will get myocardial infarction? A patient presents with a chest pain, and the physician would be probably taking history, asking for a lab test, and will have to have 2 out of 3 criteria being satisfied. On the other side, in the planned evaluation for coronary artery disease, he has a standard battery of tests of stress test, ECG, and maybe a stress thallium and other kind of non-invasive cardiological test. Those who are specialized in cardiology will go for invasive test. But as a consulting physician and diabetologist, our duty is to prevent myocardial infarction in large majority of patients. And the important role of risk equation, prediction of a risk in future, and then accordingly apply further investigation and further treatment based on the risk equation. On this, the latest development in last 3 or 4 years had been MISA study related data. A lot of publications came out. We are far ahead from Framingham risk equation, and there is more sophistication from this 6,800 individuals who have been followed up for subclinical atherosclerosis. So this particular MISA study focused more on a calcium score. They looked at different risk factors, and over 18 years, the study has gone now further into heart failure, obesity, dementia, COVID, and on the different path. But this study has thrown lot many important lights in relation to diagnosis by calcium score. So our focus today is on the plaque. The plaque builds up slowly. We all know that atherosclerosis goes on and on with aging. We do not know for an individual it starts at what age, but it's different and the progress is different in different vascular bed. The plaque biology and the progression would be different. As you can see, the pictorially plaque is shown in the right side in the lower panel where it is appeared, but this is kind of an anatomical drawing in real life, and what this expert cardiologist look at during angiography procedure is entirely different from what you see here. But the most important focus remain, as we understand as practicing physician, the plaque is a stable plaque or a vulnerable plaque. We do not come into the picture of plaque histopathology and the components of a plaque like a fibrous cap, intraplaque lipid core, and the calcium deposition. This is an example of two behavior. On the left, you have a plaque rupture. On the right, you have a plaque erosion. There are various reasons why patient develops suddenly a plaque rupture or a plaque erosion and presents with an acute coronary syndrome. But to show you diagrammatically, on the left, you have a non-STEMI infarct. On the right, you have a likely STEMI. You have a different kind of thrombus. On the left, you have a white thrombus. On the right, you have a red thrombus. And if you go into the intricacies and details on this figure, it will show you that how the behavior of a plaque could be different in different individuals and in different vessels. The composition to behavior would be totally different, and large majority of this progress of a plaque and the behavior of a plaque cannot be easily predicted by an average clinician. So we are, on the other hand, not knowing what's exactly happening, and a patient presents with an acute coronary syndrome. we come into an action to diagnose MI, think of a PAMI, or think of a conventional management in intensive care in the smaller setting where the facility of PAMI is not available. A simple question it comes to my mind. Can we measure the plaque? Is it measurable? Can we predict the behavior of a plaque? So there are facilities available in sophisticated centers. And we are moving into artificial intelligence, and image analysis on software platform can be interpreted in no matter of time. And there are interesting papers coming on that subject. The future will tell us how the behavior and everything can be modified differently. Just to show you in a second that this is a recommendation in a circulation paper almost 9 years back, or a decade back in a European Heart Journal, where a calcium artery score was considered an important parameter, level 2A or 2B indication for decision-making on what should we do regarding treatment and revascularization. So it's a well-known recommendation almost a decade back, which has not come into the practice of physicians across the country, especially in more high-risk individuals. So to take this story further on how calcium score is important in diagnosis of coronary artery disease, we have a first speaker, Professor S.M. Ashraf, who is a senior interventional cardiologist, who is a professor of cardiology and head in the Department of Cardiology at Kannur, Kerala. He has been awarded for a best challenging cases. He has more than 15 original papers and published in the reputed journals, 18 years of experience in interventional cardiology, and more than 15 interventional live cases transmission happened at various platforms for education of other doctors. So Dr. Ashraf is going to highlight in his talk calcium score in coronary artery. Over to you, Dr. Ashraf. I will stop sharing and you will be able to share the slides.
Thank you, sir. As Dr. Sanjay Shah has mentioned about the importance of coronary calcium and the prediction of the future atherosclerotic events, there is definitely a linear correlation. And mind you that the coronary artery calcium is why it is happening in coronary arteries compared to other arteries, because of the usual theory that is shear stress and a lot of branches are in the coronary artery. So the mechanism of atherosclerosis, and it is to make it calcium as an end product, is an active complex process of the atherosclerosis.
Dr. Ashraf, just sorry to interrupt, your slide is still not in full view. From the bottom you can do it, from the top it's not happening.
Yeah, I am doing that slideshow from the current slide.
On the left side of a screen.
Yeah. Is it okay?
No, it's
is it visible?
Now it's perfect.
Okay, thank you. So there are different type of calcium in coronary artery. It may be the intima, or it may be even the medial calcium. And the coronary calcium is different from other the peripheral vasculature. For example, you will see a lot of calcium in the femoral artery in patient with coronary disease. These calciums are majority in the adventitia, but in coronary artery it will be in the intima, and it is actually it's a byproduct of active complex process of the atherosclerosis. So just highlight why it is so important, as Dr. Sanjisha, Dr. Sir mentioned, it is not much important if you are taking the elderly age group or very, very young patient, because when you're taking the young fellows or with a family history, because majority of these plaques are very soft, there will not be much calcium. So if you take asymptomatic 45 to 75 years, I just copied from the, I mean Australia, New Zealand, this one, there's risk stratification, and almost similar to American ASCVD stratification. If you take that with the diabetes more than 40 years, and they divided between the low risk, intermediate, and high risk. High risk, definitely we had to go with the statin therapy and other risk modifiable drugs. Whereas intermediate risk, there is always a high chance, can be low risk or high risk. Here comes the importance of coronary artery calcium score. So these sort of patients are very common in our OPD setup with a positive, either probably in and around 50 years with a history of, sometimes there may be diabetes, and we have to know about the ASCVD. And ASCVD, it is low to intermediate, then there is a role for calcium score. And people divided calcium score with a 0 to even up to 300 to 400. More than 300, there is high risk, whereas 0, it will be very low risk. But there are a lot of myths about that, because 0 doesn't mean you are completely free. You have to. Some people are telling that you can repeat the calcium score even after 5 years, but some people are against because there is a risk of radiation, all these things. So there is a role for calcium score in an intermediate risk of Framingham's risk group. With this, we'll move to the coronary calcium. This is a direct marker of coronary disease. The need for a clinical decision, that is, it identifies younger individuals at elevated cardiovascular risk, has led to this CSC risk factor as a direct marker of coronary disease. So because it is very relatively simple procedure, 10 to 15 minutes time only, so you will get a big data on that. And even 2019 ACC-AHA guidelines of primary prevention recommend they are little bit too aggressive when compared to European guidelines. But they are telling that CSC scoring for further risk assessment in borderline to intermediate risk individual, typically middle-aged adults in whom management is uncertain. So what is the risk of MI-MACE in relation to calcium score? If the calcium score is 11 to 100, there is high risk of future events in younger individual, and more than 100 there is a high risk, and even more than 300 risk is highly likely that this patient may go into coronary or atherosclerotic events. Now come the rates of stroke and mortality in patient with the calcium score. The assessment is, you can see that stroke and all-cause mortality in a patient with more than 100 will have a high when compared to lower group. And sometimes there is issue related to, sometimes if you are not getting much calcium in the coronary, still patient can have stroke. These sort of patient we may miss if you are taking only the calcium score of coronary. So there is a easy method like carotid plaque morphology and carotid plaque assessment also in that picture help you to prevent the stroke. So calcium score is not not a definite diagnosis, mandatory requirement, but it may help in certain intermediate risk group, those who need really need of investigation. For example, the strong family history, diabetes without TMT is negative. Still, if you are suspecting any high risk of future event, like for example, HSCRP is high, in those individuals, we can send the patient for calcium scoring. So MI incidence and calcium score and duration. There is a linear relationship with the duration. More than 10 years or 15 years, you can see that with a high calcium score, more than 100, there is very high risk of the higher risk of incident of coronary disease events and 1.6-fold higher risk of all-cause mortality during the 12.5 years of follow-up. So the CS in initial evaluation suspected CAD, the coronary artery calcium scoring in detection of obstructive CAD in this CT scan, you can see that sensitivity is almost 95%, percentage and negative predictive values 98%. So in a symptomatic patient, if the score is 0, the correctly rule out the obstructive CAD and high risk of CAD in 98% of patients. So there is a negative predictive value if the score is 0. So you can tell that the risk is very, very less. Studies support the incorporation of CSC testing in the early triage of patient with chest pain and as a gatekeeper for further cardiac testing. But I will modify this sentence because sometimes the plaque rupture, you may not see the calcium. And sometimes even the CT scan machine cannot detect the very minute calciums and all. So there are some limitation on that. Now, if you take the calcium score on major global guidelines, you can see that the common indications are age more than 40 years with the intermediate risk group and asymptomatic population. And if the score is 0, you can downgrade the risk and withhold the statin. And more than 100, initiate or consider statin in case of ACC guidelines. And non-agreement points like some people want to use aspirin or not, there are debatable issues. So see that the CSC in guiding the statin use, the American guidelines with the score of 0, they downgrade the risk without withhold the statin. And the score is more than 100, they want to initiate the statin therapy. And ESC, but in fact, they are not pushing for the initiation of the statin therapy. They said upward reclassification and consider statin therapy. So they're not strong enough, but ACC is strong enough to say that the statin usage may be helpful to prevent the future events. NICE guidelines, they again say they are favoring the statin therapy if the calcium score more than 100. And people even subdivided, for example, calcium score very much high, for example, 300, 400. You have to strongly follow up this patient. You have to aggressively treat because these people are high risk of future cardiovascular events. And I already told the issues of calcium score, the very young and soft plaque, sometimes you may miss. So that's why your age group should be in and around 45 to 55 years. Early 30s and all with a strong family history, you still want to rule out, should not go for the calcium score. And if the, for example, elderly patients and with asymptomatic status with a diabetic population, especially in a renal dysfunction, definitely there will be some sort of calcium because the risk of coronary event in a 75 years is almost from 0 to 75, there is a risk is almost 75%. So there is no role for elderly population, only role for the intermediate risk group between 45 to 55 years age group. And calcium in carotid arteries and stroke, this patient may come with stroke without coronary calcification, even though it is a atherosclerotic event. With this, I conclude. Thank you for the patient attention. So just in your OPD basis, not low risk, not high risk, and with a strong family history, diabetes, with asymptomatic status, and with other atherosclerotic factors like mild renal or with a high hsCRP, these sort of patient definitely benefit with only 10 to 15 minutes of investigation like calcium artery scoring system will help you to prevent the future major events like myocardial infarction. Thank you.
Thank you, Dr. Ashraf. I have a couple of questions to clarify certain practical issues in the clinic.
Thank you, Sanjeev Shah, sir. Okay, can
you will answer first, followed by Dr. Mondal. So I would request Dr. Mondal to kindly unmute yourself. If the same question is asked to both of you, you practice way south in Kerala and Dr. Mondal practices in East. All are Indians, but we have a different socio-economic and clinical practice setting. The first and simple question is, how frequently in your kind of a referral tertiary care practice, when you see the patients, you need to ask for a calcium artery score, coronary artery calcium scoring. So how do you make a decision that you put a request? In diabetology, we go by certain different parameters as a diabetologist. Physicians will have in non-diabetic population different consideration, but in your own practice, how do you take that decision?
Good question, sir. Actually, in fact, for the last 10 years, only very few cases, those who want to go abroad and all these cases like HSCRP with the TMT is negative, still diabetes is atypical symptoms. And we are only very few cases we are sending for the calcium score, but we are getting routinely from one eminent, our own senior member from the Mangalore side, that is in the Karnataka. He used to do the calcium score for the last 10 years. Initially, I was not favoring that investigation, but on follow-up and whatever is investigation results show the high calcium score, then with a asymptomatic status, then I did the angio that's showing the some atherosclerotic disease. So nowadays we are convinced that this has some value. And he has a large experience. He is very senior to me, and he still followed the guidelines in these sort of intermediate risk group patients.
Dr. Mondal, what is your experience?
Thank you, sir. Actually, this is in my practice, I make it a routine. If there is a family history, particularly if there is a premature CAD in the family, then usually I go for calcium scoring routinely, particularly in male subjects. And also, if there is a 2 or more risk factors, particularly diabetes plus something, suppose diabetes plus hypertension, diabetes plus smoker, diabetes plus dyslipidemia, better to go ahead with one of these calcium scoring, because risk factor is risk factor. How it is affecting our internal biology, that is getting reflected with calcium scoring. Suppose a 10 years diabetic may not have any coronary plaque, whereas maybe 2 years diabetic and he was maybe 6 to 8 years pre-diabetic may have a very high calcium score. That means this effect of this risk factor on internal biology is not same from, and that means it differs from individual to individual. So if there is a 2 or more risk factor, or particularly if there is a strong family history of CAD, I usually go for calcium scoring. Even in 20s or 30s, we go for calcium scoring.
So in one of the paper publication which was cited by in Dr. Ashraf presentation, the population was between age 30 and 50 years with high risk factor. When in 4 risk factor, it was 1 in 5 was positive. That means number needed to treat for screening was 5. So higher the number of practice.
Actually, basically, number needed to treat 5 out of 1 is not bad. One. And second thing, that this Western physiology and Asian physiology is not same. We, the Asians, our presentation in coronary artery disease is more of acute thrombotic event rather than stable presentation. And European or American may present with a stable angina, whereas our presentation is more of thrombotic events, maybe an unstable angina or NSTEMI or STEMI. And particularly our CAD is premature also. From that point, that is premature plus thrombotic presentation, and this presentation may be a STEMI, I think better we should be more lenient in investigating those peoples, and particularly where the effect of this risk factor on internal biology should be assessed. And from that point, this calcium artery scoring, without giving contrast, we can go ahead just to see the calcium score. I think it is not a contrast exposure, just a mild radiation exposure, definitely. I think better to go ahead with this. We should be more lenient in using this calcium scoring system.
Thank you, Dr. Mondal. Dr. Ashraf, one very simple basic question. People believe that atherosclerosis is an aging process, which does not need kind of an intervention or investigation. So do you believe that vascular calcification is also an aging process, or there is kind of a more different kind of a damage which is happening in those people who develop calcification?
Basically, the calcification is more common in elderly, especially the renal disease patient and very elderly. And now we are coming across a lot of octogenarians and nanogenarians and age more than 75. But calcification do occur in the younger individual, and it is not an aging population. Lifetime risk of coronary disease for individual is 75%. That's actually age dependent. Whereas calcification is it's a method, it's a complex process, and product even youngsters can occur, especially in a post-COVID era. We are seeing a lot of patients with high atherosclerotic burden, and we don't know the future issues with all these population in India. Nowadays, we are seeing a lot of coming across a lot of youngsters are coming with the ischemic heart disease. Dr. PC Mondal mentioned a lot of acute symptoms are coming with younger age groups, especially post-pandemic era. So there is some role, especially this era, there is some role of these non-invasive investigations. And I don't believe it is not age-related calcium. Calcium is not age-related atherosclerosis. There is a correlation with the age, but do occur in the youngsters also.
So you would agree that if a patient was receiving low intensity statin and after an investigation was found to have calcium score more than 100, would need the change of therapy?
Definitely statin. We know that ACSVD risk group, we usually give statin, this according to the risk. We usually, especially diabetes more than 40 years, definitely we give statin. But below that, I will little bit skeptical about that. I will do other investigations, and calcium, apart from calcium, I'll see other risk factors also. And I will push my therapy little bit low threshold for starting statin.
So we'll come back to that discussion after all three talk is over. Dr. Ashraf, stay with the group for some time. You will be part of discussion group after Dr. Mondal finishes his presentation. So we move on to the second talk by Dr. PC Mondal, who is the senior cardiologist with 25 years experience, currently working at Apollo Glen Eagle Hospital in Kolkata. He has completed MD in 1996, subsequently got all MRCP degree in UK, Ireland, and Glasgow. Also worked at McGill University in Canada, and he's published 96 publications in international journal as member of CSI, API, and other associations. Dr. Mondal is an expert in cardiology who will throw a light on post-myocardial infarction, what kind of a statin we have to use, and he's going to highlight certain findings from one very important publication. Over to Dr. Mondal, you can share the slide.
My slide are visible?
Not yet.
Okay, I'm sharing now. Visible now?
Yes, just go into the bigger view.
Visible?
Small view. Yes, now you are right. Go ahead.
Thank you, sir. Thank you for your nice introduction. And I think usually we start our life with clean arteries, and we are living with some atherosclerotic plaques and may die of acute vascular events. So this is the reality that we are facing now, particularly where there is diabetes and atherosclerotic vascular disease is a segregated pandemic in Southeast Asian region. And our younger generation is facing this problem. What I was telling that acute coronary event is much more prevalent in Indian subcontinent. We have, if there is a vulnerable plaque or vulnerable neointima or vulnerable blood, all can create acute events. And most of the acute events happen in non-stenotic. That means less than 70% of coronary artery blockage. Vascular biology prefers this kind of lesions where there is only suppose 30 to 70% lesion. Those lesions are very prone to have plaque rupture and acute coronary event. And our plaque characteristic in Asian genetics is more of fibrolipidic plaque, like diabetic. And these fibrolipidic plaques are more vulnerable for plaque erosion or plaque rupture rather than fibrous or fibrocalcific. An OCT image also shows that is lipid-rich plaque with thin fibrous cap. They are more prone to have rupture. And frequency of plaque rupture in ACS patient is not a single rupture. It is most of the time more than 2 plaques are unstable. That means we may fix with primary angioplasty 1 plaque, other plaque may cure problem after 2 days. And pharmacological intervention in acute MI, not only we are taking care of this thrombus, and we are also taking care of platelet activation. We have to treat the plaque rupture, and internal milieu got inflamed. That means our vascular biology got changed and whole internal milieu got inflamed, and that microvascular inflammation is tackled by high dose statins. That means statin more of in the first 24 to 72 hours is not lipid lowering effect, rather it is a non-lipid effect of statin that is helping us. And that is pleiotropic effects of statin. It helps in reducing platelet activation. It improves endothelial functions, improves this nitrous oxide bioactivity, and also it reduces the effect on collagen and endothelial progenitor cells. They are activated to have faster healing. All these pleiotropic effects help in acute MI. And in acute event, always an inflammatory process, and they can destabilize the plaque, other plaque also. And use of high intensity statin has been shown by major trials. There is a reduction in major coronary events in the first few days, first 30 days, and up to 1 year. So statin STEMI is one such trial that shows that ST resolution and MACE is much faster and more near complete or complete if we are treating with high dose of statin. And not giving statin at the time of this STEMI increases the arrhythmic mortality got increased also. And that is a problem that we may, if we are not treating with high dose statin, chance of NSVT related death is also high, and that can be up to 3 times. And benefit of early statin therapy in patients with acute myocardial infarction who have extremely low density lipoprotein cholesterol. That means LDLC is not a guide. That means initial level of LDLC is not a guide, all to be treated with high dose statin. And this 2019 ESC guideline suggests that in very high risk patient, guideline recommends LDLC goal of less than 55 milligram per dl with the use of high intensity statin. That means rosuvastatin either 40 or 20. Most of the time it is 40. And cumulative incidence of MACE after MI decreases with high intensity statin. And high intensity statin reduces event by 43.3%. And higher statin dose was dose dependently associated with lower risk of MACE also. That means repeat event will be much, much less. And all-cause mortality in post-MI state with high intensity statin is definitely lower. But how low is most efficacious? That's a question. Still, guideline is suggesting around 55 or less than 55. But is that safe? That's a question. Goals in Indian context, that very high risks in acute setting, it should be definitely less than 70, preferably less than 50. And that kind of level can be achieved by high intensity statin, and in stable patient, if not achieved, then PCSK9 inhibitor. But PCSK9 inhibitors are not well tested, and that means their effect is not reflected clinically also. But this high dose statin, as per some Italian study and European study, shows that it should be continued for a few months up to a year. How low is still safe? That's a big question. Whether there is an increased incidence of cancer and intracranial hemorrhage. These two big issues, besides myotoxicity and hepatotoxicity, that will be either in a short term bad effects. Severe adverse events rates for intensive versus moderate intensity statin. All these mega trials shows prove with TNT, A to Z ideals, all shows that high intensity statin is tolerable and side effects are not so great that we have to reduce the dose. Regarding effects on cancer incidence by reduction of high intensity statin, this meta-analysis shows there is no clinically significant increase in the incidence of cancer. And regarding intracranial hemorrhage, this meta-analysis shows that there is just a bit higher incidence, but that is also not clinically significant. So with all these, this high intensity statin is definitely needed for all acute MI patients. And this CVD events and IVAS data shows additional benefit from low and ultra low LDL. And a growing body of evidence suggests that LDL-C levels can be safely driven to very low levels in individuals at high risk for acute coronary events. Thank you.
Thank you, Dr. Mondal. So an important question comes as patients who were receiving low intensity statin or no statin prior to MI, how long they should continue high intensity statin, and whatever high dose you have used in acute setting. I suppose lot of studies earlier were done with 80 milligram loading dose. And many doctors or cardiologists subsequently reduce the doses. Or if a cardiologist has not reduced, then many physicians on follow-up perceive that such a high dose of a statin, whether rosuvastatin or atorvastatin, is not necessary. So there is a tendency for a physician to reduce the dose of a statin. Partly, patient would argue that we have modified the diet post-MI, post-discharge. We are now very strict on a fat content, oily and a fried food and all those excuses. Under that excuse, the physician would take a step. So what should be the strategy? Would you recommend and suggest about 1,000 physicians who are listening in this program? Dr. Mondal first, followed by Dr. Ashraf.
I think in this area, a discussion with the patient and family member is the prime thing. This should be made understood that this kind of therapy is not only to reduce your cholesterol level. This, you have an acute MI means you have coronary artery plaques, and that is not a single plaque. Your arteries, either in the coronary artery bed or in other vascular bed, you have plaques. That can get progressed, that can create problem, and you have to continue this drug in high dose so that all these plaque get stabilized. Chance of repeat event will be much, much less. And another thing, there may be a slight reversal also, though this reversal is a myth, may not be a reality, but this should be counseled. Whatever you're doing, that's good, but you need this drug also in high dose unless you have bad side effects. We are monitoring those side effects and we are looking into it. Your liver, your muscle, in your other areas we are taking care of, and you have to continue this. And benefit to be discussed with the patient and patient relatives. I think that can improve the drug adherence, because this adherence to this drug in such a high dose is definitely a questionable thing otherwise. I think that can solve most of the problem, and better to continue this at least for 1 year, if tolerable, if there is no such bad side effects.
Dr. Ashraf.
Yes, sir. Basically, majority of Indian patients and amongst also, we won't continue with the high dose statin. But when you see the prescription outside India, those who are from United States or Middle East, they are still with a very high dose of statin. And there the evidence also. We have to teach the patient that if you are diabetes, your LDL, the goal has to be nearing around 60, 65. And it is rather than the LDL reduction, there is a plaque stabilization, a regression of the plaque. So majority of time, this is the issue based on muscle symptoms, because our body mass is less. So even there is no a lot of routine prescription of investigation like CPK, because the myositis is very, very rare. Routine myalgia can occur up to 10% of the patient. In these sort of patient, you can reduce the statin and add ezetimibe. And even some very rare patients are having not tolerate the statin. You have other bempedoic acid is available in the market. So we have other options also. So we had to teach the patient, rather than LDL reduction, there is a plaque stabilization and the regression of the plaque with the hydrostatin, and also much pleiotropic effect also, class effect also. So that is my answer. Majority of time, majority of our patients are now very, very elderly. These sort of patient in subset like say, chronic kidney disease, you have to be a little bit cautious with a very high dose statin. Those patients, you can always reduce half in the statin. Otherwise, we have to be aggressive initial strategy, and the goals has to be the international standard. The LDL reduction has to be in and around 60-65 in a high risk or acute coronary event patient.
Thank you, Dr. Ashraf. Dr. Manoj Chopra was live. Dr. Manoj, are you? Dr. Manoj has a third talk. Dr. Manoj, you are there? Yeah, Dr. Manoj is now visible. In the meantime, Dr. Mondal, you have attended or offered PAMI in the culprit vessel. But many times patient may not have isolated single vessel block. There may be 30%, 50% or 70% block in other arteries. So patient would need aggressive treatment and a secondary prevention. Even if you have stented one culprit artery, your strategy would involve managing the disease in other different arterial territories. So will that be helpful?
Yes, yes, sir. Definitely. In this group, I think this high intensity statin along with antiplatelets is definitely needed, and plus one myocardial infarction means they have reached their border, that this acute event has already happened. We should not go for a second event. That will be the answer to the family and the patient. And high intensity statin should be continued. And this high intensity statin, in my thinking, it should be continued for at least 1 year. At least 1 year. Even the LDL comes down to 40, 45, 30, it is not a problem unless there is a objective evidence of some toxicities, either myotoxicity or hepatotoxicity. Unless it is there, I think better to continue. LDL level just 70, 65 is not acceptable if the patient is having visible coronary artery atherosclerotic plaque in other vascular bed also, particularly in other arteries in the coronary bed also. In those patients, we should be more aggressive rather. And they should be counseled, this should be continued. Most of the time, their family physician may reduce the dose. They need counseling also, that it is to be continued to prevent another.
We have two levels of doctors below cardiologists. One is a consulting physician, second is a family physician, and now we have a third level, which is Dr. Google. So people are likely to refer to any one of the three who will tend to believe that too much is too bad. So Dr. Manoj, would you like to opine? Kindly unmute. Dr. Manoj.
Basically, we all are talking about the secondary prevention, and for secondary prevention, hydrostatins is required, right? And basically now, if you look at all our practices, what we are targeting is that the baseline LDL cholesterol is 100, then try to achieve it at 50. So 50% of the baseline levels. So I think all in fact we should do a lipid profile with at the time of admission only, and then we decide that how much LDL level you want to achieve it. Now, in many times, what basically hydrostatins at least for 2 to 3 months, and then depending upon the LDL cholesterol level, we can decide that how much dose we need to continue. Now, about the PCSK9 inhibitor, if the patient is a young, long stents are there, diabetic patient, stent patient has undergone a plasty and again comes back to the ISR, I think their LDL cholesterol should be below 40 or 30 so that the restenosis of the patient of having ISR, there will be no re-events. So I think individualized approach will be very good because a lot of Indian people talking about the muscle pains, and if you're using a rosuvastatin, of creatinine also becomes important. That mind that also should in the mind. Statins, atorvastatin, we say that it's much. The rosuvastatin is a potential. It's more potent than the atorvastatin, but again, the safety-wise or the monitoring of SGOT, SGPT, and I think individualized approach again will help us in this.
નેટવર્ક ઇશ્યુઝ કે મારે છે મને સમજાયું કેમ કેમની ટોક ચાલુ કરી દઉં. So let's keep couple of questions pending, and we move on to the third talk by Dr. Manoj Chopra. Dr. Manoj is a senior interventional cardiologist with 25 years of experience practicing at Magnum Heart Hospital in Nashik, Maharashtra. He had been the second in India to perform robotic angioplasty, which is something a unique technical achievement. He has worked as a principal investigator in more than 50 clinical trials, as a fellow of Society of Cardiology, API, Indian Medical Association, is many luminary awards, business icon, and Dhanvantari Award. Dr. Manoj, again, we find you missing from the screen. Dr. Manoj was going to talk on impact of statin therapy on coronary plaque and evaluation by intravascular ultrasound. Dr. Manoj, you are going to share the slides or?
Yeah, there's some. Yes, sir.
Yeah, kindly share your slides.
Neil, can you share the slides, please?
Yes, Nehal. Okay. Dr. Manoj.
Yeah. Hi, good evening, everyone. I think the two speakers talked about the coronary calcium, the important risk score or which has been included in and then we had a discussion about coronary syndrome and the impact of statin therapy on coronary plaque. I think the statins played an important role in a management of atherosclerosis and the plaque. secondary prevention. Next slide. Next slide. So whenever we talk about the plaque, atherosclerotic plaque lesions are a type of lesions, and the natural history of atherosclerosis probably complicate various events such as plaque rupture or erosion. And I think that's the most important erosion, thrombosis, and patient presenting with acute coronary syndrome or myocardial infarct. So type 1 is the initial lesion, type 2 is fatigue, type 3 is intermittent lesion, fourth is atheroma lesion, that will lipid. Type 4 is a atheroma lipid core and the fiber layer, or a multiple course and main calcium fibrotic. And the complicated lesion is basically a surface defect, hematoma, hemorrhage, and the thrombus. So whenever the plaque rupture occurs, that causes the problem, and that's how the type 4, type 5 lesions converting into a complicated lesion. And the patient, next slide, please. So whenever we all talk about the plaque, if there is a erosion the acute event because of the pool, the thin fibrous cap, microcalcification, and all this expensive remodeling. These are the events about so focus in a 40% in proliferation. And all these things or all these changes which occur in a plaque gives a stability to plaque, and that clinical events or clinical benefit is there and the event is reduced. Next slide. So we all talk about how do we assess this all our investors, the idea about the CT, coronary angio, or MR. We assess this, the patient is going for an invasive, culprit vessel is done, then the other vessels also has a plates or there the IVAS, OCT, what I invasive IVAS and OCT play important role in this. Play important role in this, and imaging the load or a fight in OCT important role in this, and that's how we can decide about the treatment plan. Next slide. So high risk plaque features. These are the different presentation positive plaque which has occurred. The napkin ring sign, that's a low attenuation area, everything by high attenuation ring. Spotty calcium has a small focal calcification in otherwise non-calcified plaque, low attenuation plaque, equivalent of lipid-rich components. Next slide. Next slide, please. Next slide. Yeah. So this plaque regression, statins reduce the cholesterol deposition because the IVAS OCT analysis gold standard for plaque quantification. Resolution allows visualization of the cap, fibrotic, and MRI. These are the tools, and they can be used. Next slide. Bubble plot demonstrating the demonstrators and you can achieve LDL cholesterol levels, the low better. Next. Next slide, please. Coronary CT angio for plaque and stenosis quantification and cardiac risk prediction study. Novel deep learning convolution coronary training and almost than 5,000. And a network was upset, which included an extrapolation cohort of 165 patients, that is 1,000 of the and we look at the target events of total plaque volume, percent diameter. We total diameter was agreement for the total plaque volume and the minimal luminal area. Next. So basically, artificial intelligence was used to find out the plaque volume and the stenosis. And the prognostic value of deep learning based plaque measurements for in 1,600 patients. MI occurred in 40 or higher. Prediction is clear the pathology and the plaque and the myocardial. Next trial. Next slide, please. So basically, if we look at the this data, I think IVOS plays an important role, but again, it does. So I think CT angio and nowadays atherosclerotic risk for the patient having a risk score more than 10, and where we generally want to find out that the coronary atheroma is there or not, and if you are really using the statins and that click regret, if we are really interested in because
Thank you, Dr. Manoj.
so yeah.
I have
Yes,
one
sir.
very important question for. I have one very important question which Dr. Manoj followed
Yes.
by Dr. Mondal both will answer. When patients have suffered, a patient has seen on coronary angiography that there is kind of a block in my coronary artery.
Yeah.
Every patient is expecting that by taking a prescribed medication, full list of drugs, whether my plaque or the block will regress or not. So my simple question, physicians would like to know, at what LDL level plaque is likely to regress? As Dr. Mondal in his previous comment has mentioned, post-MI, there could be some regression. Sometimes these are something which is difficult to measure even by follow-up coronary angiography. So do you have any experience where follow-up angiography revealed regression of a plaque in some people?
Yes, I think, sir, there are patients where there is an aggressive, not only the LDL cholesterol, but if he is a diabetic, hypertensive, sugar control, BP control, patient is obese.
Dr. Mondal, are you able to hear him?
No.
We can't hear. Dr. Mondal will answer.
Okay. Can I answer now?
Yes, I think.
Dr. Chopra, with your permission, I am answering.
Yes.
Okay. Actually, this reversal study shows that there may be some kind of reversal, particularly in acute coronary lesions. That means what we are seeing, a patient of unstable angina have a critical lesion in LAD, and there is a suppose 50% lesion in RCA and a 60% lesion in LCX. And an angiogram of 1 year after this event, there may be some regression of the plaque in the RCA. Maybe LCX lesion is same. Now, is it a real regression, or that plaque in the RCA was also complicated with some intraplaque hemorrhage, or some plaque edema because of inflammation is a complicated plaque? Sometimes this complicated plaque, when gets stabilized, their volume get decreased. Suppose intramural hematoma was there, intraplaque hemorrhage was there, that got resolved and the plaque got fibrous, more fibrotic, then its volume get regressed. That means it is a complicated plaque that is getting stabilized and its volume become less. That can be the scenario. Real reversal is not a reality. We are not seeing any that reversal will be there, and that is a definite reversal. Most of the time, this kind of reversal, particularly after introduction of IVUS and OCT, that means imaging studies, it shows that there is a reversal only in those plaques which was complicated earlier. Now it is stabilized and the plaque volume is much less and percentage area of block is much less. That means it is a just change of nature of plaque. The material is not going out. Just change in the nature of plaque, that is giving the idea or ideation that this volume is getting decreased and percentage of area is getting reduced. That means improvement in the percentage stenotic area.
Thank you, Dr. Mondal. Is it likely also sometimes in some patients that observer variation, who
Yes.
probably reported higher percentage block last time and now reported different observer later on a repeat study shows lesser?
Actually, if we want to compare the percentage of block before and now, we should go with QC analysis. That means a device-based analysis, not a person doing this analysis. That means it is a QC analysis is required. And that means a plaque quantification and quantitative assessment should be there. It is not a person-dependent assessment of block that may be erroneous. So error will be much more. It should be a QCA-based analysis that can give an idea whether the plaque volume has decreased or not.
And the last question of the day, Dr. Mondal, some of the people across the country claim that by some kind of naturotherapy or some kind of other therapy, they achieved a reversal of the block.
I think that's a myth, I think, and we are not ignoring those, but those who are therapy are based on, suppose, on some exercise, some yoga, that is definitely acceptable.
Comprehensive care, lifestyle, all
That-
medications and
that-
all
that is
herbal
acceptable.
medicine, Arjun and whatnot.
Actually,
all-
medicine, any use of any medication should be scientifically based. Unless that is tested regarding its effect and side effects, we shouldn't allow that. But regarding non-pharmacological endeavors, daily life change, sleep wake cycle change, lesser use of your laptop, phone like this, and daily habits of exercise, daily habits of yoga, these are definitely acceptable. But pharmacological interventions should be scientifically evaluated before allowing them to use it. Because unless that is assessed by some testing or by some trials that this is definitely effective, it is not getting people harmed, then we can allow those. Otherwise, any kind of pharmacological thing, that may be diet, that may be some herbal medicines, all to be tested first. Otherwise, non-pharmacological area, that is acceptable, we can accept this. But pharmacological area, I think that should not be allowed.
Thank you, Dr. Mondal, for those final words. With that, I would conclude the session and close the session. Thank you all for joining and staying till the last question. Thank you all faculty, Dr. Ashraf, Dr. Mondal, and Dr. Manoj. We apologize that there had been a little difficulty with the internet connection of Dr. Manoj. However, we still, with moderating and two other experts, we have made an attempt to highlight the subject of coronary block, plaque, and post-MI therapy.
Thank you, sir. Thank you.
Thank you all. Thank you for joining on Saturday evening. With this, I close the session.
Thank you.